So it's just past 6, and it looks like we've got a packed house, which is amazing. Thank you so much for being on time. I'm going to get us started. I'm going to kick everything off. So I want to just start by saying welcome to the Algoma Citizens Reference Panel on Integrated Care. On behalf of my entire team, I want to just say thank you so much for joining us today. I know that when you probably received that brown envelope in the mail, you kind of opened it and went, what the heck is this? And I cannot say just how grateful we are for your commitment to improving healthcare in the region. And to me, when folks respond to this call to action, it's a real testament to your commitment to civic responsibility and your commitment to strengthening society in the communities that you live in. So I want to begin just by commending that and recognizing that it's an honor to be here with you all tonight. I know that Rukhsaar sent out the agenda to everyone, and I'm sure that you've all taken a peek at it, and you know that we've got quite a packed evening. So I'm going to just jump right into everything, so getting us going. But my name is Laurie. If you haven't met me yet, me along with my colleague Rukhsaar, we will be hosting the panel, but we're also joined by an amazing facilitation team who you're going to get to meet a little bit later tonight. And we're going to be we like to call ourselves your civic concierges throughout this whole event. We're here to make sure you folks feel supported and that you have everything you need to participate in this reference panel. So just a quick overview of what's in store for tonight. I'm going to quickly go over just a few tech things. It was pretty clear based on the getting settled that folks are pretty comfortable, but I just want to make sure everyone is good to go. And then we're going to basically kick off tonight with some learning. So I want you to think about this in 2 ways tonight. We're going to be learning largely about 2 things. One is going to be about the process, about what is a reference panel, how you got here, how we're going to be working together. So we're going to cover that tonight. And the second thing that we're going to cover is we're going to actually start to give you some of the context, some of the information you're going to need to know in order to do the task that we've assigned you. So we're going to kick it off with 2 presentations. One is an orientation to the healthcare system in Ontario, and the other is about the role of primary care in the health system. So you're going to get to learn a bit about that tonight. So to quickly go over the tech check. So I just wanted to mention here that, whoops, I went too quickly. We've got, I guess, 4 major buttons that I want you folks to think about. The first one is the mute button. As I mentioned before, it's possible that we'll mute you, but if you want to unmute yourself, bottom left-hand corner, you click on it, and then we'll be able to hear you when you want to ask a question or jump into a conversation when you're in your small group breakout rooms. The video button, right next to that, if ever you want to turn your video off, you click on that and it'll turn your camera on and off. The other button is the chat button. That's the one with the 3 dots. That will pop open the chat box, and you can use that to type in when we have Q&As with our speakers or in your small group activities. If you prefer to use that, that's an option available to you. And the last one is to raise your virtual hand. And you're going to be able to do that by clicking first on the reactions button. You'll see a little thing pop up, and then you'll see the raise hand button. But don't fret if we don't figure it all out tonight. We've got a few days together, and I'm sure we'll all be Zoom experts by the end of this. I see that a lot of folks have had the chance to find the chat box, but if you haven't, I'm a big foodie. I love to cook. I love to eat. If you want to just drop what your favorite food is, figure it's dinner time, might as well start thinking about some food. It'll make me hungry, and then I'll be able to catch up on that a little bit later tonight. So the other thing, a lot of you also figured this out, is just some ground rules in terms of Zoom. And I know that Chim and Rukhsaar and Mel have gone over this, but I do want to just restate it, is we know that Zoom can be hard and it can be a little annoying and frustrating to always have your camera on. So if at any point you want to turn your camera off, you want to get up and grab a glass of water, you want to just stretch or whatever, you do you turn your camera off. There's no offense going to be taken. We also want to encourage you to eat, to drink, to stretch, to move throughout all of our time together. We recognize that we're not able to meet in person, and we're going to make the best with what we have and use Zoom, but we also know that movement is good, it's healthy, so join us in doing that. I know that me and my team will be taking stretch breaks and eating breaks throughout this entire thing, so you're more than welcome to eat during a presentation and hang out with us. The whole idea is we want to get as comfortable as possible. And the last thing that I just want to mention is when we have our guest presenters speaking, I would just ask, unless there's a major tech issue or something that's come up, just to avoid using the chat box. Otherwise, the person who's speaking just keeps on getting pinged with notifications and it can just be a little distracting. So that's just an ask that we're making of folks. But as soon as we get to Q&A, just hop back into that chat box. That's where we're going to go to ask some questions. And just a word about pacing and technology. We know it's not perfect, but we still think that despite all of this, we can achieve really great things even during difficult times. And I'm going to suggest that in order to do this, we do two things. One, we use some patience. If something goes wrong, it's all going to be okay. We'll take a small break. We'll use it as an opportunity to stretch and grab a glass of water. And quite frankly, we'll always use a good dose of humor. We'll laugh it off, and then we'll get back on track and rejoin the meeting if something happens. Hasn't happened yet, but I always think good to plan for it in case it ever does. And if all else fails, call Rukhsaar. She's on our hotline. It's the 1-833-426-0799 number. It's the number you've been calling us on since the beginning. If anything goes wrong, you need any help, you pick up the phone, you give her a call. You can also private chat with her in Zoom, or if none of those work, you can try sending her an email, but that will be her slowest option when we are on the reference panel together. So that's it for my tech check. As I mentioned, when folks ask, I'm joining from Toronto. A number of my colleagues and teammates are joining from different places across the province and across the country. And you're also joining from different places across the region in Algoma. And so I wanted to invite Marlene tonight here to kick us off by opening up the ceremony with a land acknowledgement as well as an opening ceremony to really just set the tone and help us just get settled in. So Marlene, I'm going to hand it over to you, but I do just want to let you know a little bit about Marlene. I got to chat with her before this, and I have to say it is quite an honor, and I'm so happy that you accepted our request to speak to our group tonight. Marlene Syrette is from the Ojibwe Nation, and she's a member. I think we've got the sound going. That's okay. Thank you, folks. I'm going to start that all over again, Marlene. You deserve to be introduced. But Marlene is from the Ojibwe Nation and is a member of the Wolf Clan, and she's enrolled with the Batchewana First Nations of Ojibways. However, her parents are originally from the Gadigan-Zibi, also known as Garden River First Nations. And one of the things that I talked to Marlene about, and that was so wonderful to hear about, was ever since she was a child, Marlene is somebody who has really lived a cultural lifestyle. And from a very young age, her parents encouraged her and instilled in her a strong sense of identity, as well as a desire to live a rich ceremonial life. And when I talked to Marlene, she told me that yes, she had studied fine arts, but really that she thought most and her best education had really come from her parents, from her lodge family, and her elders, who really taught her tradition, medicines, and ceremonies. And today, Marlene works with Nagda-Wundaman Family and Community Services, as a traditional knowledge keeper, and she has agreed to open our ceremony tonight. So Marlene, I'm going to hand it over to you to speak to us.
Miigwech, Laurie, for that great introduction. And I just wanted to say that I'm very humbled and I'm honored to be here today with you all, and to offer up some good words to start off your sessions in a really good way. As Anishinaabe people do with gatherings and groupings like this, we always ask for good direction, clarity, and guidance in everything that we do, from meetings to our ceremonial doings that we have. We always ask for good direction and guidance, and for a good outcome as well. So I guess I'm going to start by just sharing a little bit of a land acknowledgement. And coming from this area, I've lived in Sault Ste. Marie, which we call Bawating or Bawatugum. And I've lived here all of my life. As Laurie had stated, I would like to really acknowledge that, our hospital, our Sioux Area Hospital in here in Sault Ste. Marie is within the Robinson Huron Treaty. And I think as is most of Algoma. But, you know, this area, in the Ojibwe language, we call it Bawating, as we know, for those of us that live in the Sioux, we have the, they say it Bawading High School, but the original way that we say that is Bawating. And just to break that down a little bit for all of you is when we say that word Bawat, it refers to rapids, like in a river. That's what that translates to. So when we add that ing or ong at the end, you're making it locative. So you're saying at the rapids. And this is historically is what Anishinaabe people have called this area. In a historical sense, this was our traditional fishing grounds. And it was also what different nations had come here to the hub of the Great Lakes, or the heart of the Great Lakes, to do trading with cloth, even with medicines. So, you know, it was like Grand Central Station for the Anishinaabe people at one time. It was a big trading place. And also, you know, the rapids and, you know, the heart of the Great Lakes is a very sacred and special place for the Anishinaabe people. I guess, you know, to acknowledge also the Batchewana First Nation, the Garden River First Nation, which we call Gitagon ZB, and, you know, were the original signatories for the Robinson Huron Treaty. And these are the two nations, or the two communities that had signed at that time. And also to acknowledge the Métis community that's in the area, to acknowledge them. And, you know, these are the nations which occupied this part of Turtle Island since time immemorial. And we give thanks, and we want to acknowledge the historical and the sacred sites that are within this area. You know, one of the examples of that is the pictographs up at Agwa. You know, we have, it's a very special site for the Anishinaabe people. We have, you know, living history that tells those stories of what that is and what that means for us. And people have tried to figure out, you know, what was used for those paintings on the rock. And, you know, it was a very sacred and special paint that was made historically. And, you know, that's another day. But I just want to acknowledge all of that. And also, you know, the ancestors who lived and hunted and fished and used the land in this area, you know, historically, and just really made paths, you know, for our younger generations to hopefully use the land in the same way, and to have that respect for Mother Earth. So yeah, just a bit of a land acknowledgement there for the Ojibwe and Anishinaabe people who occupied this land. So with that, Laurie had stated that you know, this opening in Anishinaabe way, you know, we always offer up our asema, and that translates to our tobacco, but it really doesn't like mean tobacco. It means something that we use to communicate in our way, in Anishinaabe way. And I shared some teachings with the Sioux Area Hospital. We made a video explaining what these medicines are used for, and how historically, you know, we've always had this, and we acknowledge Mother Earth for providing and sustaining us with everything that we need to survive. So I'm going to just go through a prayer to ask good things to happen, and to acknowledge those certain things, and just give thanks for life, and for all of us, you know, being able to gather here today in a really good way, and to do the work, and to learn some things about, you know, what it is that, you know, integrated care means for the Algoma region. You know, there's so many stories that I could share as far as, you know, the healthcare system, and how, you know, it can be integrated with our Anishinaabe ways of healing as well. with our traditional medicines that we do have. One of the examples is, our red willow, for example. We harvest that. I just harvested a bunch in the spring, and there's different purposes, but ultimately it's a medicine that we use for pain. And wouldn't you know it, the pharmaceutical companies harvest it and they use it to make aspirin. So our Anishinaabe people have known this forever, and we would go out and harvest it and use it when needed. So just that acknowledgement as well, from giving that one of many examples of how Anishinaabe and natural medicines can be integrated into, the healthcare system in a really good way. The two can work together. And, another example of that is, I was talking with another lady about, the maternity wards in the hospital. And within my family, we always gathered that. We asked for that placenta after that baby was born, because we consider that to be a sacred part of our bodies. We don't consider that to be biomedical waste. We have a ceremony that takes care of that. And in the beginning, at the Sioux Area Hospital here, the shock on the nurses' faces when we were asking, for that. But we had to really explain what that meant and how that placenta ceremony happens for us. And we just asked for respect and understanding in the way in which we take care of that. So after they understood and they knew that information, it was just, every time an Anishinaabe woman was in there giving birth, they started to ask us, would you like your placenta? And I thought that was so amazing. I thought it was so, what a sign of respect that it was for me and my sisters, my relatives, community members that were in the delivery. It was nice to know that our maternity ward staff was understood it enough to where they must have been having conversations about it. And if there was an Indigenous woman in there, they would always be so kind and respectful to ask if they would like the placenta. So, that's another example of how integrated, our Anishinaabe ways are within the healthcare system. So I just wanted to share a little bit of that before I get started on the prayer. And I'm going to use my Ojibwe language to do the prayer. And I don't mean to exclude English speakers, but basically it's a prayer that's acknowledging, the day, acknowledging the Creator, giving thanks for life, and really just, acknowledging in a grateful and beautiful way. There's, in English, it doesn't do it justice to try to translate. I do my best, but it's such a beautiful language, and there is really no English will not do it justice. So, we acknowledge the different elements that were brought in. We acknowledge our Mother Earth. She gives us the food, the water, everything that we need to sustain life. So we give thanks for that. And it's also going to acknowledge all of you here in this meeting, the citizens reference panel, and Apachiko Miigwech Bijayeg Nongum citizens reference panel. Apintendagwazim. And what that means is that thank you to all of you who are doing this work. You are all highly valued. So, it acknowledges each and every one of you and your contribution to this work and to, the next few weeks that you guys are going to be together here in this platform. So I'm going to light my medicine. I have a smudge here, and I'm just going to let my asema, my tobacco, burn in the smudge. And it's important that when we do that, we have our asema. And it is said that, by my elders and ancestors that, our prayers and our good words and our good thoughts and feelings are carried up through that smoke to the Creator, to Gijem Manido. So when a bojo nin dinaway magani dog, bojo gaki na oia, ogi mabane sikwe and vision a cause, wabshki maingan ndodem, Ojibwe and Ishnabe kwe and dao, Bawatagong minawa rankinish kunjining and duljaba og. Apachago miguet gija manido au manopa madaziwan minawa mano gijigat. Odapana binda kujige au asema gija manido minawa gaki na mano manidog. Apachago miguet wabanang jawanang ninga bianang minawa giwedanang bishomasanonic minawa nakomasanonic. Apachago miguet when a buju minawa ogo masan. Miguet gija manido. Ginage go gimeje eyong minawa ningo dinge gijik apachigo miguet gaki na mino manidog ivide jawanang wabanang jawanang ninga bianang giwednang apachigo miguet Citizens Reference Panel bijayeg nungum inanokiayajig apin tendago sim inanokiayajig. So when I acknowledge all of you, I'm going to, in my asema, I'm going to ask that, you know, for these sessions, it brings guidance, clarity, and understanding for each and every one of you to know what it is, you know, that to understand what it is you're going to be learning and to share with the community, you know, on your findings. I think that's important. And if there's anything that, you know, you would like to know further about Anishinaabe, Odsawin, we call it Anishinaabe lifestyles, and our ways of healing and our ways of traditional medicines. And if anybody has any questions about, you know, what that means, you know, just ask Laurie for my email, or, you know, you can contact me through, I'll send Laurie my cell number, and I will be so glad to answer any questions or even just hear comments or ideas. But, you know, in this good way, we ask for that clarity, guidance, and understanding for you all, and really let you know that you are all highly valued for being a part of this group, and really acknowledging you in a loving and a caring and respectful way. And that's what we do as Anishinaabe people in the language. We ask for that, and it's in a very, very respectful way that we ask that for all of you, for each and every one of you to come together in a really good way. So with that, I want to say, Apachigo Miigwech Bizindawieg, thank you for listening. And I want to say, Migo Ma Akawe Minik Inwewe Tuyan. That is all I will say for now. So Apachigo Miigwech.
Well, thank you so much, Marlene Miigwech. I know from the chat that there's been a number of people who have been saying thanks in Miigwech as well. So I cannot thank you enough. It was such a pleasure to meet you a few weeks ago. And as I said earlier, I cannot thank you enough for agreeing to so kindly and generously open the Citizens Reference Panel for us tonight. And it is really in the spirit of integration and in reconciliation that we really wanted to bring this perspective to bear and really set the tone tonight. That when we're talking about integration and we're talking about health, we have to think about, you know, the systems that are maybe more familiar to us, but we also have to think about the cultures and the preferences of people who might not be as comfortable in the systems that we're used to, or who have different practices like Marlene was talking about. So I really appreciate you bringing that to bear, Marlene, and sharing that story about the hospital and how just, you know, once people start to learn, it breaks down a lot of barriers, right? It's sometimes we don't know what we don't know. And when we're not able to, you know, understand why someone else is doing something, it's hard to put ourselves in other people's shoes. But being able to have these conversations and to learn together is really something that we're going to ask all of our panelists to do. So I really appreciate you taking the time to come and join us tonight. Thank you. I'm going to ask everyone to virtually clap. Usually when we do this in person, we are big clappers. So we're all going to virtually clap and thank Marlene for joining us and for sharing with us and for opening the reference panel. Marlene is also going to be joining us at the very end too. So this isn't the only time we're going to see her. She's going to come to the end and also close the reference panel. And she's also invited to hear your report at the end. So she's going to be following us along throughout the entire process. So once again, thank you so much, Marlene. Thank you. I am going to go back to sharing my screen for 1 second. So just bear with me as I get this set up. Okay, is it showing? It looks like it is. Folks see it? We're good? Okay. Okay, so as I had mentioned earlier tonight, we are going to be, one of the learning goals for this evening is to help you better understand what the heck a reference panel is. I bet most of you probably have lots of questions about it. So we're going to break our orientation tonight up into 2 parts. So the first part is really going to be talking about your role, the task that we've given you, how you got into the room tonight. We want to make sure that that is crystal clear to folks. You're probably all wondering what you have in common, which makes a lot of sense. And then the second part is going to focus on how we're going to work together. So we're going to, a little bit later tonight, I'm going to tackle that. We're going to talk a lot more about what our agenda is, what the activities are, and how we're going to support you through the task and through the 6 days that we're going to spend together. So that's just a little breakdown of what to expect in our orientation tonight. And I'm going to ask Stephanie, if you're in the room, are you here to come off mute?
I'm here.
Okay, so I know that many of you have had questions about what the Algoma Ontario Health Team is, why they've convened you. And so I've asked Stephanie just to say a few words to you folks. Stephanie is the patient partner lead at the Algoma Ontario Health Team. She was one of the folks who signed the letter that you received in the mail. So you can put a face to a name. There'll be a few of them appearing throughout the panel. But Stephanie's gonna just say a few words about the health team, about the tasks that they've asked you to do and how they're going to be using that to forward their work as an organization. And I know that there'll probably be lots of questions about the health team, so I just want to reassure folks that we've got 2 whole sessions tomorrow focused explicitly on the demographics of Algoma and explicitly on what the health team is, what its mission is, and how it's working. So we're going to make sure we got you covered for that. But Stephanie's just going to get us kicked off tonight with a few words on that front. So Stephanie, I'm going to hand it over to you.
Great. Thank you, Laurie. So as Laurie mentioned, my name is Stephanie Parniak, and I'm one of 3 tri-chairs of the Algoma Ontario Health Team. We have a chair from Sioux Area Hospital, a chair from Primary Care, and I am the Patient and Family tri-chair. And I'd like to welcome all of you on behalf of the Algoma Ontario Health Team and our partners across the East and the North. We are one of 42 new Ontario health teams across Ontario. We are one of the newer health teams, which is very exciting. And these health teams are partnerships across health, social, and health promotion services that are working together towards a more integrated health system for our Algoma residents. And so when we're talking about integrated care, it's a technical way of saying that we're working towards providing coordinated or wraparound services for patients, their families, and our community. So we stop looking at individuals for a specific disease, and we consider them as a person and within that broader context of their health and their social well-being. And as we start looking at the care that we provide outside the walls of the buildings, we plan more effectively with our partners. I recognize that this is a huge time commitment from each of you, and I'd like to thank you for accepting that invitation to be here. I know you're probably wondering, what am I here for? And all of that is going to roll out over the next little bit. So just a little bit about myself. I do not work in healthcare. So a lot of times I hear terms which are foreign to me, and I've had to ask questions saying, what does that mean? Or, so make sure you ask questions if you're not too sure exactly what something means. So my experience with the healthcare system is as a patient and as a family member. And as a patient of the healthcare system, one of the really important lessons I've learned was the importance of advocating for yourself and the need to have a more integrated system. So 4 years ago, I was diagnosed with cancer. And it was that journey that really empowered me to want to advocate for others who might not be comfortable advocating for themselves. I was blessed. I had family members and friends who were able to come to appointments and translate that medical jargon for me, but not everybody has that luxury. And so really wanting to make sure that we're empowering and providing the best care we can for residents of Algoma. So my treatment involved several different healthcare professionals, both here in Sault Ste. Marie, I'm a little nervous, and in Sudbury. And it really would have been nice for everyone to have been on the same page and have access to the same information as far as my care. So often I'd be, get a phone call from one person saying, well, this is what we're doing. And someone else saying, oh no, but this is what we're doing. And, really wanting to make sure that everybody's on the same page. And that is what we're working towards. We're working towards that integrated healthcare system where everybody's on the same page. And that is on team patient and team family member. So for the last 3 years, I've had the privilege of serving as a member of Algoma District Cancer Program's Patient and Family Advisory Council. 2 of those years I was chair. And when I finished my term with the ADCP PFAC, I joined on as the patient chair of Algoma Ontario Health Team Leadership Council. So we are so excited that you are here. And we've invited you here because we really do want to move towards a system where citizens are meaningfully engaged and involved in the priority setting. No longer just telling you what we think is best for you. We want to hear from you what you think is best for the residents of Algoma. And we looked at how we could do this, and we came across the Citizens Reference Panel, and we thought it was just a great idea. It gives us the opportunity to hear from a representative sample of citizens who can learn together about the healthcare system, who can deliberate, and you have amazing leaders who are going to guide you through that process. And so we are grateful for all of them. As a partnership of many organizations, we're looking forward to hearing from you in terms of what are the values and principles that you'd like us to embed in our work from the very beginning, and identify your highest priority actions for us to take in strengthening care closer to home or to deliver health services across the community. So there are a few different different items that we're hoping you'll help us with producing. And the first is creating a patient declaration of values, or the Algoma People's Health Charter. So what are the principles? What are you expecting to be upheld in advancing integrated care? What needs to be present? What is important to you as citizens of Algoma? And part of having this diverse group is because everybody may have different answers, but we might recognize some common themes, and that's what we're working towards. You'll also be able to influence the creation of the Algoma Ontario Health Team's first strategic plan by highlighting citizen-identified priority actions. Where do we need to be going in our healthcare system here in Algoma to meet the needs of Algoma citizens? We know that it's not always the same across the province, so we are focusing on Algoma. And we're going to share all of this work with health and social organizations and health providers who are working across the region. We gather at a table called Leadership Council, and it isn't just to talk about what you're saying to us. We want to work towards implementing what you are sharing with us. And so as the Patient and Family Tri-Chair, I am grateful for all of you again, and I'm really looking forward to working with you over the next few days, the next few hours, and into the weeks and months to come. I'm hoping that we will continue working together after the Citizens Reference Panel is complete, and I'm happy to share my contact information with Laurie as well. So if you have any questions or anything you'd like to chat about that you you have access to myself as well. So thank you again so much, and enjoy the homework that you're going to be doing for the next little bit.
Thank you so much, Stephanie. And I thank you for explaining who the health team is, and also for explaining how you're going to use their work, and for really walking us through why it's so important to put patients and citizens really at the center of thinking about health systems design. Not always the most common way to do things, but definitely a step in the right direction. And I'm so excited that we're here today, and that you folks have all volunteered to be part of this process. And I just want to reiterate two things that Stephanie said. So first off is medicine and health systems can be a technical world with a lot of acronyms and jargons. Do not feel intimidated. Do not feel embarrassed if you don't know it. Like Stephanie, I'm not a healthcare expert. I'm not a health systems expert, and neither is anyone on my team. So you might hear me kind of chime in and pop in and say, what's that term? Can you explain it? And I would welcome you all to do the same thing. The whole reason why we're here is to demystify, to really kind of pull back the veil and to let you in and help you understand the context. And it's on us to make sure that we're giving you the information you need to be able to do that job. So just wanted to say 120%, couldn't agree more with Stephanie, that jargon, it might happen, it might pop up, but we're just going to ask people to kindly explain it to us, and there's no shame in that. And the second thing that I wanted to reiterate that Stephanie said is really just the fact that you're all here donating, volunteering so much of your time. And as I mentioned at the very beginning, this is really no small feat. But we're so grateful that you're here to join us. And I'm actually going to invite my colleague Rukhsaar, who's a co-host. Many of you have probably already met her because she's our kind of lead civic concierge on this project, to actually walk you through a little bit more of how you got here, what your role is, and what the task that we've given you is, to kind of explain that in greater detail to you. So Rukhsaar, are you here?
Hello. Hi.
Hey, Rukhsaar.
Thanks, Laurie. As Laurie mentioned, over the next few minutes, I want to speak more about how we got here and what our task is. I have a few slides I'd like to present on this, and then we'll take a break and jump right into our first presentation. But first, how did we get here? Well, you may recall receiving a letter some time ago in April through the mail. Came in a little brown envelope, and it had the logo of the Algoma, Ontario Health Team, and it read, "Health services in Algoma are changing and we need your help." Now, some of you responded to one of those 7,500 invitations, and these invitations were randomly distributed across the Algoma region by Canada Post. Others may have responded through a call for volunteers from community organizations. Quite frankly, you're here because you won what we call the civic lottery. You were randomly selected to participate in this panel. And this isn't an opportunity that everyone has. In a few slides, I'll explain exactly how this is an important fact to keep in mind as you begin to work together. Yeah, Laurie, next slide. And this isn't the first time that we've actually run a civic lottery. By volunteering on this panel, you have joined thousands of other Canadians who answered the call to join a reference panel. Sometimes they're also called citizen assemblies. Our team, including Laurie, myself, and our skilled facilitators, have all run 40 panels across the country in the last 10 years on a wide range of topics. So trust us, you're in good company. And if that's how you got here, then let's talk about why you're here. And while it's certainly special that you were selected through this lottery process to sit on this panel, you're really here because all of you want to strengthen the health system in Algoma. And next slide. When it comes to your task, as you probably read in the letter and in the welcome package, your task is to first learn about the health system in Algoma and the challenges facing it. We've built a robust learning program that we feel will help you do this. And then we want you to also understand different perspectives and approaches, which is why we've invited over 20 different speakers who will share their perspectives and experiences with you. We also want you to consider how different approaches like integrated care or primary care, things you will learn about, could affect different communities throughout the region. Ultimately, doing all of this should allow you to work together to define principles for integrated care and provide detailed recommendations for strengthening care closer to home. But to put this another simpler way, together, your job is to work on behalf of all residents in the Algoma region. This means we'd like you to not only think about the needs of your families or your personal needs, but to really put yourself in other people's shoes. Next slide. So when you think about your role on this panel, we want you to stretch yourself, okay? Yes, think about your own experiences, certainly do that, but also think on behalf of those who couldn't be here today. That is to say, those who are not as lucky as you. Think about the 150 folks or so who volunteered for this panel, but were not selected. She wants to join too. We want you to put yourself in their shoes. Then we want you to go even further and think on behalf of the 7,500 residents who were invited to participate on this panel, many of whom really wanted to be here, but couldn't make any of those dates. Finally, we want you to think on behalf of everyone in the region, even those people who didn't get an invitation, but would have really wanted to have a seat at the table and just didn't receive an invite. And though there are only 36 of you, you will be proposing recommendations ultimately that will affect everyone in Algoma. Next slide. And while that might seem like a huge, daunting task, acting on behalf of over 100,000 residents, we have created a program, as I mentioned, and as Laurie will go into greater detail later on, that will support your learning and ensure that you're able to work together to make informed recommendations on behalf of Algoma residents. In the second part of the orientation, Laurie will walk you through the schedule of this program and will hopefully help you better understand how we'll work together. But awesome. I think we're about to do a break, right?
Yeah, well, I was just going to ask if folks had any questions about the civic lottery, how they got in the room. We do have a few more minutes, but I do want to make sure that we give you a chance to stretch before we settle down. From between 7 and 8 p.m., we're going to have 2 back-to-back presentations by some excellent speakers. And yeah, so any questions before we break for a little bit and come back at 7 p.m. to kick our learning program off? Ali, I see that you've rose your hand? Your hand's up.
So you've mentioned there was roughly 150 people that opted or volunteered for this opportunity that were unfortunate not to get chosen. Now, would they be more likely to get chosen for another opportunity? Or, I mean, personally, I just feel bad. You know, I know how excited I was, and I wish that they have that opportunity in the future.
Yes, it's a great question. So this isn't an all or nothing opportunity in the long game. We do, when we're doing the reference panel, we do select 36 participants for our reference panel. It allows us to work in small groups of 6. So we have 6 groups of 6 that work together to form 36 people. The other folks who were not selected to participate in this round, though, are going to be considered for future opportunities. So what we did with this civic lottery, because the Algoma Ontario Health Team, as Stephanie mentioned, is such a new organization, we also recruited folks for the reference panel, but folks could also send in a response card or sign up online to volunteer for other future opportunities. So what we're also doing through part of this process is not only convening the 36 of you for this, but really starting to create a pool of people who are interested in participating so that we can reach them later on and actually widen the kind of ring of participation more broadly. This is really just the kickoff, like Stephanie said, to a much longer process that's working towards the articulation of that strategic plan, but that's not the end of it. Once you have a strategic plan, you got to figure out how to put it in motion. So Yes, they weren't chosen for this particular activity, but we haven't forgotten them. They haven't just vanished into the abyss. But part of the civic lottery process is that, you know, some folks end up kind of winning and other folks just aren't selected. And that happens both in the round with those 7,500 invitations. We don't know who they go to. We just tell Canada Post the geography that we want to cover, and they kind of randomly distribute it, which is why we have to ask you to answer all of those questions again. And then likewise, when we do the second round for the panel, it's also a bit of luck kind of comes in. But great question.
Oh, for sure. No, I get that. I was just inquiring about future opportunities for them because that was of curiosity. That's about it. Thank you, though. You answered my question.
No, I love how you're also thinking already on behalf of these other people. What good energy to bring to the room. Any other questions about how you folks got here and what we're asking you to do? Okay, silence on Zoom usually means no, but if I've misinterpreted that, this is not a one-time kind of window of opportunity for your questions. So you're always welcome to ask them to me a little bit later or at another date, or you can drop them in the chat. But I do recognize that we're here for 3 hours tonight. It is dinner time. So if you haven't had a chance to eat yet, I would encourage you all to take the next 13 minutes. We're going to reconvene at 7 p.m. sharp to hear from Dr. David Marsh, who's going to give us an orientation to the health system in Ontario, a real 101 who's who in the zoo kind of presentation. But for now, 13 minutes, stretch it out, go get some water, go grab some food if you need to eat, and we'll see you all back here at 7. Thank you so much for joining us. Okay, so I see that most of us seem to be back at our screens, which is great. I love it. You guys were also prompt showing up at 6. You're all prompt showing back up from break. These are all very good signs for our group. So we're going to get started. So we're moving into the kind of second part of our evening, and we're going to start now learning a little bit more about the health system. So I've invited Dr. David Marsh to speak to you about the health system in Ontario. And I must say, I've given him quite the task. It is I'm real glad and quite impressed that he's accepted the challenge that I've given him, which is to really give you guys a 101, a primer on what the health system in Ontario looks like, to start to describe some of the actors in the system, and also to talk a little bit about some of the bigger challenges facing the system more broadly, and to do that all in 20 minutes so that you all have about 10 minutes to ask him some questions. So we have to be kind. It's really not an easy task to explain such a complex system in such a short amount of time. So thank you so much, Dr. Marsh, for agreeing to speak to our panel about this. And for folks, I just want to take just a second and introduce Dr. David Marsh, who is joining us from the Northern Ontario School of Medicine, where he is the Associate Dean of Research, Innovation, and International Relations. Prior to joining NOSM, the Northern Ontario School of Medicine, that might be a name. NOSM might be a term we hear throughout the panel. It's one of the medical schools up in the region. So when you hear NOSM, NOSM, know that that's what folks are referring to. But prior to joining the Northern Ontario School of Medicine, Dr. Marsh, also worked over in BC at Vancouver Coastal Health. So he's joining us with a wide range of experience, having seen systems in different provinces and how they work. And he's also an award-winning doctor who is noted for his work on the treatment of opioid independence. So I'm going to hand the mic over to you. I think you should be able to share your screen. We tested it before, but let's just see if it's working. It is. Excellent. Are you good?
Yeah, I think I'm good. Thanks, Laurie.
Perfect. Thank you so much.
So as Laurie said, I'm currently at the Northern Ontario School of Medicine. I mean, currently in my own home, but I work at the Northern Ontario School of Medicine. And I'm going to try and talk to you about the health system in Ontario. Now, I will let you know I'm not a health economist. I don't formally study the health system. I have worked in Newfoundland and Ontario and BC and back in Ontario in healthcare delivery as a physician, as a healthcare administrator, and now at the medical school. So I'm speaking mostly from my experience and what I've picked up along the way. And my goal is really to give you a kind of broad brushstroke picture of some of the issues in the healthcare system and how it's maybe intended to work, some of the barriers for it working smoothly, but mostly to set the frame for the other panelists who will present later and the discussions that you'll have throughout the rest of this experience. I have no funding from drug companies or medical device companies. I do, in addition to my position at the medical school, I'm the chief medical director for Canadian Addiction Treatment Centers, which I get a stipend for. And most of my income actually comes from my clinical work that I do. So the objectives for the next 18 minutes or so, to try and help you understand some of the history of the health system in Canada and Ontario, to understand how the system's structured and funded. And I think it's useful to know how it's funded because sometimes the behavior of systems is driven by how the funding is streamed. But also it can help you understand certain barriers to changing the system when you understand how the money flows. And then I'll follow with a list of what I think are important challenges facing the system in Ontario, and I'll try and relate them to the Algoma region for you, but that'll be the bridge into our discussion. So one of the key things to understand about healthcare in Canada is the division of powers between the federal and provincial government. So in brief, the Canadian Constitution or the British North America Act set up a division of powers between the federal government and the provincial governments, which clearly defined a narrow scope of responsibility for the federal government in terms of services that they have to deliver. The military, responsible for Indigenous peoples, import and export and trade, foreign relations with other countries. So a very narrowly defined set of responsibilities, but an open-ended taxation ability. And the provincial governments had just the opposite. They had a narrowly defined ability to tax the population, but essentially anything that wasn't the responsibility of the federal government automatically became the responsibility of the provincial governments. And in fact, healthcare and health was originally included explicitly in provincial responsibilities, even back in the 1800s. This setup in our federal provincial division of powers, the way the federation is set up, was intentional, and it was partly designed so that there would be some national standards for services and expectations of what the population could get from government. It also was set up that way so that there would be a redistribution of wealth from the relatively wealthy, industrialized, trade-driven provinces of Nova Scotia and New Brunswick to the relatively rural, resource-driven and impoverished provinces of Quebec and Ontario. Now, the names of the provinces and the nature of the economies have changed over time, but the principle is still there, that the provincial governments have very broad responsibility, but are not able to raise enough money through taxation to cover those costs. And the federal government redistributes wealth from province to province, sets national standards. The Canada Health Act in 1984 was a revision or updating of earlier acts that set out the access to universal health care in Canada, really established key principles that physician and hospital services in Canada are publicly funded. So remember that there's only parts of the healthcare system that are mandated to be publicly funded, physicians and hospitals. With respect to those services, all the provinces should have public administration. So the insurance scheme that pays for physician services should be publicly administered. The services should be comprehensive, universal, portable, and accessible. There's a lot of argument about what those words really mean when you get down to the details. How portable is our healthcare when we move from province to province? How universal is the access when there are differences between provinces and certain types of services that are covered or not? But those are the core principles of how the hospital and physician services are intended to be delivered in Canada. And then there's a Canada Health Transfer that sets up a movement of money from the federal government to the provinces to help meet those criteria. And of course, there's a lot of politics about how much the transfer should be, whether or not it's increasing at the right rate, how different provinces compare to each other, and so forth. But the provincial governments have to deal with this dilemma of delivering a healthcare system that's universal, portable, accessible, comprehensive, publicly administered, including all physician and hospital services, that grows with the expectations of people, with the growth in the population, with the changing nature of services. And the provincial governments really have to grapple with that while trying to control costs. So this is a picture of total healthcare expenditure per capita in Canada in 2019. You can see that hospitals are the biggest single component of the healthcare system in terms of dollars. 26% of the healthcare spending is on hospitals. Physicians at 14% is the next largest, and very close third are drugs. If you include prescribed and non-prescribed, so over-the-counter drugs, medications cost Canadians more than physician services at this point. And then there are a range of other components, some of which are publicly funded and some of which aren't. So public health, which is publicly funded. Some of the capital, some of the administration are publicly funded. But there's a lot of other healthcare services that are basically paid for by private dollars, either through the insurance that you get through your employer or because you pay for the services yourself when you receive them. And in some cases, some of these, like certain dental services, certain vision care, are paid for by public systems to a segment of the population. So people above a certain age, people who qualify for income support or other social benefits and so forth. And that's the same with drugs. Many people have to pay for their own medications. Some people have public coverage for medications, but then there are limits on what medications are or are not covered by public plans. So the public funding covers hospitals, physicians, public health, some of the medication costs, some of the community services, some components of home care or home care for some people, some components of long-term care. But if you can afford to pay thousands of dollars a month for your long-term care, then you may be able to access facilities or services that are not accessible to people who don't have that level of additional funding to support their long-term care. There's a lot of talk about the increase in healthcare spending. Frequently you hear kind of doom forecasted that if the healthcare spending keeps increasing at the rate it is, it'll eat up the entire provincial budget. It obviously already is the largest single expenditure for provincial governments in Canada, but there's no provincial government in Canada who spends 100% of their budget on healthcare. This really tracks the annual increase in healthcare spending after accounting for inflation from 1976 to 2019. And you can see there have been phases. There was a whole phase in the 70s and early 80s when healthcare spending was increasing about 2.7% a year, higher than inflation. So this is the kind of growth that eats up more and more of the provincial government's budgets. Then we went through a phase in the early 90s when healthcare spending was increasing more slowly than inflation. That was followed by, again, a period of relatively rapid increase in healthcare spending. And now for the last decade, healthcare spending has been pretty well under control, not that much higher than inflation across Canada. Another way of looking at it is, rather than comparing it to inflation, comparing it to the gross domestic product. So gross domestic product is kind of a measure of the overall economic activity in the country. And you can see that for most of the last 20 years, the line here, the increases in healthcare spending have been pretty much consistent with the increases in the GDP. Now, that throughout this same period, there's been a lot of pressure on governments not to increase taxation at the same percentage that GDP was increasing, to keep total taxation as a lower and lower percentage of GDP, especially decreases in taxation on corporations that could move their business from country to country and go to locations with the lowest tax rates. So the fact that healthcare spending is changing in line with GDP doesn't necessarily mean that it's not increasing in the pressure that it puts on the provincial budgets, but it does show you that the kind of concerns that healthcare spending is exploding out of control and needs to be dramatically cut is not really supported by the economic data. If you look at these different segments of the healthcare system and how the costs have been increasing, for the last 20 years, the hospital sector has been having the smallest annual increases in funding, barely keeping up with inflation. And so it's really been a sustained period of time now where hospitals across Canada have been pushed to become more and more efficient. This has had a number of impacts. They've been moving services to outpatient rather than inpatient, and very short, much shorter lengths of stay for services that used to have longer lengths of stay. So gallbladder surgery, routinely people would be in hospital for 5 days. Now they go in, maybe go home the same day or the next day. Women giving birth, normal child delivery, much shorter lengths of stay. But even other more serious and even life-threatening health conditions, lengths of stay are constantly being pushed shorter and shorter as much as possible. And during the time that patients are in acute care, they're more acutely ill than they were in the past. This puts a constant pressure on the hospital to deliver good quality care, to have staff who can manage more and more complex and complicated patients, can integrate new technologies, new electronic health record systems, and so forth in order to facilitate that efficiency. And so it's a constantly changing, dynamic, kind of pressured environment. This also puts pressure on the community sectors in order to try and deliver services like health promotion and prevention that can prevent people from getting sick in the first place, or if they do get sick, can identify the problem and treat it early enough and in such an effective way that it prevents them from needing to be admitted to hospital. Or if people do end up in hospital, can manage them at home or in some alternative care environment after the discharge. So constant pressure on community care providers to take patients that are sicker with more complicated medications, that may have different types of dressings or IV fluids or medications that historically they never would have managed in the community setting, all to free up beds in the hospital in order to deal with the pressures that the hospitals are under. And you'll see this talked about in terms of alternate level of care. So ALC, or alternate level of care, is a designation for somebody who's in a hospital bed physically, but in the opinion of the healthcare providers in the hospital, does not need to be in hospital. In other words, if there was a level of care available in the community to manage their problem, they could be discharged, cared for in an environment that's much cheaper for the system, and free up that bed for somebody else who needs to be in the hospital or is maybe waiting in the emergency room, waiting for a bed. So this flow of patients into the hospital and out of the hospital, the impact that has on healthcare costs and quality of life is really one of the main issues in the healthcare system, and obviously an important issue in the Algoma area. And I'm sure some of your future presentations will talk some more about that. Physician services, people often don't understand how physician services work within the system. Physicians are almost never employees of the hospitals. Physicians are autonomous professionals. They essentially operate as independent business people. They charge almost all of their services to a single insurance, the publicly funded insurance, or OHIP in Ontario. And from the money that they receive from OHIP, they have to cover all of their costs for rent and staff and equipment and so forth. Now, many of the services that physicians deliver in Ontario are reimbursed on a fee-for-service basis. This means they get X number of dollars every time they see a patient or every time they do a surgery and so forth. There's a relatively complicated insurance scheme that lays out the different fees for all these different services. Not all physicians, however, are paid on an individual fee-for-service basis. There are emerging models for physician remuneration that focus on having a list of patients that they're responsible for, whether they see them 10 times a year or twice a year. But the idea is to try and incentivize the physicians to deliver more health promotion and to help the patients to stay well so that overall healthcare costs are reduced, quality of life is improved, and people avoid late diagnosis, complicated presentation, and hospital admission. Those sorts of models are particularly applicable in primary care. And I know Dr. Newberry is going to talk to you more about primary care at a future talk. Another trend in how healthcare has been evolving in Canada has been regionalization. So over the last 20 years, there have been various models of regionalization tried in different provinces. Ontario was one of the last provinces to try regionalization, and really the Ontario model that is now currently being revised, I would say was one of the weakest models of regionalization. So in some provinces, what they do with regionalization is try and isolate health decisions from political decisions. So it's some level of governance that's intermediate between the provincial Ministry of Health and the frontline care providers, the hospitals and community agencies. And it's usually got a geographically defined catchment area. And the idea is that within that geographically defined catchment area, like the Algoma district, they'll be better able to develop communication with the population in that region, figure out what their healthcare needs are, and innovate ways to deliver health services to meet the needs of that population, and develop partnerships between community-based and hospital-based service providers. Those are still basically the ideas behind regionalization. In some provinces, when they created these regional health authorities, they did away with all of the boards of all the hospitals, sometimes did away with the boards of all the community-based agencies, and created a single governance structure for all those services. That sort of more powerful regional health body could then move money from one hospital to another or from the hospital to community to try and shape the healthcare system around the needs of the population in their geographic area. Ontario never did that. All the hospitals still have their own independent boards, their own CEOs, and so forth. The 14 local health integration networks would develop a service mandate agreement, and the money would flow from the Ministry of Health to the LHIN and from them to the hospital or community agency. Problem is, every hospital board could go to their local MPP or to the Ministry of Health directly and work around the LHIN. So there were a lot of inherent structural weaknesses in the LHIN structure that limited the LHIN's ability to really integrate services. Public health in some provinces is included in the regional health authorities. They have not been included in the local health integration networks. And now public health is being brought under the new Ontario Health umbrella. So there's a new province-wide body called Ontario Health that's then broken down into Ontario Health North that covers all of Northern Ontario. And the public health units and public health districts are under that Ontario Health umbrella, but still exist as separate districts. Public health district boundaries and the local health integration network boundaries never did line up. But now we have Ontario Health teams emerging, and they will be closer to the community level and have a ideally better opportunity to integrate community and acute care services. And I know somebody's going to talk to you more about Ontario Health teams later. So I think I just have a couple of slides left. This is an idea of the different stakeholder groups that ought to be brought together to help plan the healthcare system, determine what the community needs are, set priorities for how the healthcare delivery should be developed and evolved in order to meet the needs of the community, really placing the needs of the people who are served at the center, and having universities, medical schools, health professionals, policymakers, the healthcare managers in the hospitals and community agencies, and the communities all work around and together as equal partners to try and identify the strategies to meet those needs. And so I'll just wrap up with this list of what I see as some of the challenges you might want to discuss, and I'm sure you'll have other ideas. So the challenge of keeping pace when the population size is changing, the needs of the population are changing, there's new technology, there's growing acuity, all while controlling the costs. You'll notice that I didn't mention the aging population. There is obviously demographic data around the aging of the population, but there's reasonably good data to suggest that the aging of the population is not driving increasing healthcare costs. And maybe one of your other presenters will talk more about that, or we can talk about it in the question period. The issue of smooth transitions and timely access to care when moving between the home, community providers, and acute care and back ideally to the home. Trying to balance investments in health promotion to improve quality of life and prevent illness versus investments in more expensive and technologically advanced care and acute care or other expensive settings. Figuring out how to solve the alternate level of care dilemma. Is it possible to build enough long-term care and community care set resources to eliminate the ALC pressure on acute care? There's a lot of electronic health record systems, some very complicated ones, including there in Algoma. The Group Health Center has a very advanced electronic health record system. That means a lot of information which can be used to measure the effectiveness and efficiency of the system to drive quality of care. But it's important that we protect individual privacy while we do that. And Ontario has some pretty good legislation around that. For Indigenous people, they are a specific population where the federal government has a mandate to deliver healthcare. And there are Indigenous populations and reserves within the Algoma district. The federally funded and delivered healthcare services have never been sufficient to meet all the needs of Indigenous people. Part of it is a matter of scale. There aren't enough Indigenous physicians and nurses or enough patients requiring open heart surgery for every reserve to have a hospital that can do open heart surgery. Part of it is that there's no legislative or regulatory requirement that sets out the level of care that's expected of the federal government for Indigenous people. And a lot of it is just historical underfunding. But Indigenous people, as a result, draw healthcare services from both federally and provincially funded sources. And there's a lot of opportunity for those different systems to work better together and for more self-governance, with solid evidence that communities that have stronger self-governance have better health outcomes. Setting national and provincial standards, again, driven by the needs of the population, prioritizing access based on need rather than ability to pay. And then, as we've seen with the issues about access to vaccines manufactured in Canada, figuring out how to foster research and development and production of medications within Canada while controlling costs. Historically, our system is focused more on controlling medication costs, and as a result, we have very small investments in research and development and manufacturing, and new medications tend to come here years later than in other countries. So that's a quick run through, kind of bird's eye view of the healthcare system in Canada. I realize I went a little bit over time, Laurie. I apologize for that, but I'm happy to answer questions.
That's okay. Rukhsaar, do you want to handle the
Q&A?
Q&A?
Yeah, we can share a quick Q&A. I think we maybe only have 5 minutes to ask Dr. Marsh any questions we may have about his presentation, anything that we learned about the health system in Ontario. Made some very interesting points about the division of power between federal and provincial. Does anyone have any questions? June, let's hear from you.
Okay, well, thank you, Dr. Marsh, for being with us tonight. I just have one question, and it's regarding doctors coming up here to the north. Do they get a like something like to say, come on up to the north, and do they get any extra funding or anything to draw them to come on up here and to work with the people up here in our area? I just wonder that.
Yeah, that's an excellent question. There have been a whole range of different schemes to try and create financial incentives to recruit physicians to rural and northern environments. Many of them don't really work very well, or only work for a short period of time. There is a very active locum program that results in doctors moving temporarily, like for a few days, a weekend or whatever, to cover different physicians' practices. And so a lot of Toronto-based doctors spend very short periods of time in Northern Ontario. The best way to increase the number of physicians in Northern Ontario is to recruit people who have grown up in Northern Ontario, train them in Northern Ontario with good clinical experiences in rural primary care settings, and then they're much more likely to go back to those settings. And the NOSM model, if you look at the percentage of students who return to Northern Ontario or to rural practice, is doing very well in that way. The challenges were just a very small school. So it might be 15% or 20% of our students who graduate and end up practicing in rural family practice, over 50% who end up practicing in Northern Ontario, but there's still only 64 of them each year. So we're looking to try and grow the class size at NOSM and produce enough physicians practicing in Northern Ontario to try and keep up with the people who are retiring. And Sarah Newberry, again, will potentially have more to say about that later.
Great, thanks so much, June. Excellent question. Shalom, I saw your hand go up.
Yeah, I'm not sure if you'd be able to speak on this, but I know specifically for the Algoma region, the group health center is a large part of it, and it's funded differently from other physician organizations in other parts of Ontario. Can you speak on how the group health center is differently funded? Does that make sense? Because I just know that in terms of how it's funded as opposed to physician groups in other parts of Ontario, it is very different.
Yeah, I only know very general terms about the group health center's financial model. I know it has an alternate funding plan. And so it's more like the model of the family health teams than the fee-for-service model that dominates many other parts of the healthcare system. I'm hoping that Dr. Newberry knows a little bit more of the details of how the group health center works.
Yeah, I think the funding model probably speaks to what you were talking about, different physician remuneration models that are out there to encourage more community health promotion. David, your hand went up next. Let's hear from you.
Hi there. I was wondering, Doctor, you had put up some graphs about the variation of costs for healthcare, and I was curious how that relates to patient outcomes. And so have patient outcomes been consistently sort of following that same sort of trend, or are they continuing to improve, or how does that relate? And then a second question that I'm not sure, you may not be able to answer, but it's as we're thinking about and listening to the presentations and so on, what horizon are we thinking about when we think about the recommendations that we're ultimately making?
I think I'll leave the question on the time horizon for your recommendations to the hosts. On the question of patient outcomes, there's no single measure of patient outcomes. Life expectancy is the closest that we have, and it generally has been going up in Canada, except for the last couple of years with the increase in opiate overdose deaths having a negative impact on life expectancy. But generally, over the time period that I showed in those graphs, life expectancy has been getting longer. But to really understand patient outcomes, you need to look at different health conditions and define clearly how you want to measure the outcomes.
I see. Thank you.
Great, perfect. I think we only have time for one more question. I'm gonna go to the chat. I see Douglas asked a question about hospital beds. Douglas, do you want to come off mute and ask your question for the group?
I see.
Okay, well.
So the question is, how does an empty hospital bed save money if most costs are fixed? That's an excellent question, Douglas. Yeah. An empty hospital bed does not save money. What happens is one of two things. If people are able to be moved out of the hospital, then it means that somebody else who needs the care can move into that bed. So you get more patients through the hospital in the same period of time. And people get better care than they would receive if they were in the hallway in the emergency room or waiting to be admitted because their surgery had to be delayed because there was no bed for them to be in, right? So getting people out of the hospital and allowing better access to care is one of the factors. You do save money if you can have a group of beds that are empty and you close them, and then you reduce the staff that would be used to serve those beds. So usually it's a cluster of 6 or 8 beds that if you close, you can reduce a certain number of FTEs of nurses and pharmacy and so forth. And then you really do reduce the cost in the hospital. Some hospitals at times do bed closures in the summer or certain periods of time. Less so now that there's so much pressure on hospital beds. But when I was starting out in my career, there was always a seasonal slowdown in the operating room. Some of the operating rooms would close, some of the beds in the surgical wards would close, and the staffing levels would be lower. And that's how you save money, by having fewer staff. Does that answer your question, Douglas? Thanks.
Yes, I have Dr. Newberry, sorry. I have your biography. Just want to introduce you to the group a little bit. Folks, Dr. Newberry has tons of experience working on the ground with patients. She's here to introduce us to the term primary care, talk to us a little bit about primary care and explain its role within the health system. Now, Dr. Newberry completed her medical school at McMaster and postgraduate family medicine training in Thunder Bay in the Northern Ontario Medical Program. She's been a rural physician in comprehensive community practice in Marathon since 1996, and she was chief of staff for 16 years. She is a past president of the Ontario College of Family Physicians and is the Assistant Dean of Physician Workforce Strategy at the Northern Ontario School of Medicine. Awesome. She's on several provincial health-related committees and is a mom to 2 now grown sons. Am I saying their names right? Mateo and Ari?
Ari, yep, very close.
Ari, and partner to Eli, who is also a rural family physician in Marathon. She's passionate about access to care for citizens of Canada's rural and Indigenous communities, and about primary care as the foundation of high-performing health systems. Wow, Dr. Newberry, tell us about primary care.
I will be happy to talk a little bit about that. And I'm just going to set up to share my screen here, and I'll check and make sure that you can see that okay.
You're all good.
Great. All right. Let me just set up to play from the start. Now, I often struggle to keep my eye on the chat as we go along, but June, I did pick up your question about physician workforce strategy, and I'll post a link to that in just a moment. So as was just mentioned in that lovely introduction, thank you for that. I'm a rural generalist family physician. I've been here in the community of Marathon for 25 years, and I spend a lot of my time thinking about primary care and thinking about primary care as one of the cornerstones of integration of high-performing healthcare systems. I don't have any conflicts to disclose except my firm belief in the importance of primary care for all citizens. I want to begin, though, with my thanks. It really is terrific to be joining you today, and I'm joining you from the traditional territory of Anishinaabe people, and specifically the Ojibwe people of Bigtugong First Nation in the Robinson Superior Treaty area here just north of you. I want to acknowledge as well that what I'm going to share with you is not original thinking for me. It is really the product of many, many thought leaders in primary care, both in Ontario and in Canada, and truly around the world. But I also want to say that I think what I've learned the most about the importance of primary care, I've learned from patients and colleagues. And so I'm grateful to all of them for helping to shape this thinking, and really grateful to all of you for your interest in the healthcare system and for the thinking that you will do about primary care. I wanted to share with you a little bit about where I live and work, and give you a bit of a visual of the primary care and the integrated healthcare system that we have here in Marathon. And for those of you who are here from Wawa and from Blind River, this probably will look quite familiar. So the top right picture is our hospital. We have 12 acute care beds and 12 chronic care beds, the usual hospital services, lab, x-ray, physiotherapy. In the bottom left, whoops, I didn't mean to advance my slide. The bottom left is our senior supportive housing. We have 36 seniors who live there in an environment in which they can be supported. And then in the bottom right is actually our clinic. So our clinic is the entire top floor of that building. Our public library is on the main floor. And now in COVID times, our assessment center is on the other half of the main floor. And each of these buildings is within about 100 meters of each other, with the ambulance base in the middle. The high school is about 200 meters away, and our public health unit is there. And within our primary care setting, we also host staff who work for home and community care. So we have a very highly integrated hub of care. And in the Ontario context, we've come to call that rural health hubs. So we have a highly integrated rural health hub. I wanted to just level set a little bit about what primary care is, and Dr. Marsh touched on this as well. But in really, really simple terms, primary care is the day-to-day care that's provided by a physician or other qualified healthcare provider like a nurse practitioner. Primary care is the setting which is expected to be the point of first contact for patients in the healthcare system. So, you probably hear sometimes that emergency department visits are too high, a variety of things where we're trying to redirect people from some points in the healthcare system to primary care. The expectation is that primary care is going to be that first point of contact for most people, and the place from which they enter into other parts of the system, like mental health and addiction services or hospital-based services, and the place where their care can be coordinated. And why does that matter? Why are we talking about primary care, and why are we talking about it particularly now? I think it's important to understand that high-functioning healthcare systems around the world have primary care at their foundation. And that is really, really important for the overall population health. I want to introduce you briefly to a concept called the patient medical home. And that what the patient medical home does as a concept or as a vision for care is really articulate a set of expectations. So for some of you who have been in other urban settings, Sault Ste. Marie is very organized, I think, overall in terms of their primary care, and very fortunate to have group health. Other urban settings will have many walk-in clinics. They'll have single physician offices in strip malls. They might have large academic settings that are associated with the university. Highly, highly variable settings for family physicians and nurse practitioners to work. And we have not, in Ontario, articulated an expectation of what should be happening in primary care, what all family physicians, nurse practitioners should do in a primary care setting as that point of entry. And so the patient medical home is a way of articulating that. And I want to say that this is not a new concept. It was first introduced in the United States, actually, in 1969. So this has been around for a long time as an idea. And it was introduced in Canada in 2011. So we've had many, many, many conversations about the importance of the patient medical home. And we've had many places where it has been implemented in sort of pilot kinds of ways. In Ontario, family health teams are probably the closest thing that we have to the fully implemented patient medical home. And only about 25% of people in Ontario can access that kind of model of care. So what you'll see across the bottom is what are considered the foundations. So administration, connectedness, or an ability to connect to the rest of the system through an EMR or through other communications kinds of technologies. And then some expectation of administration and funding. And in many solo family physician offices or small family physician offices, that infrastructure, that administration and funding is generally funded from the money that the physician receives through their fee-for-service billing, and is highly variable, the extent to which physicians invest in their practice setting. The most important part, though, is really the functions in the middle, because the functions in the middle are what you experience as patients, as family caregivers, as citizens entering into the primary care system. And there are 5 core functions of primary care that drive the value of primary care in the healthcare system. So the first is accessible care. It's not helpful if family physician offices are only open on Tuesday and Thursday afternoons. We need primary care to be open and available to patient needs as much as is possible. And so many practices over the last few years have moved to more evening and weekend hours. More practices are engaging with patients by email, by text, by secure portals for messaging in an effort to try and increase the accessibility of care. Patient and family-centered care is really important as well. We need primary care settings to be focused on the patient and family care that they deliver and to make sure that it's responding to the needs of individual patients. And we know that a huge part of what drives value in primary care is the continuity of relationship. So it's the relationship that patients have with their family physician or nurse practitioner, or with a team in primary care, that creates value. And I have many, many stories of patients who've come to see me who I've known for a very long time, who've been experiencing chest pain or another symptom. And because I know them, because I've seen them and come to know them and their family and their stresses and their context, it's easy for me to talk through what that chest pain might be, if it's stress or anxiety, and why that might be more likely than a heart attack, which is the thing that they're worried about. But it's in the relationship and the continuous care over time that we can actually help to optimize or deliver best value in terms of the care we provide. The next is comprehensive team-based care. So part of what we want in primary care is for patients to receive the care that they need from the best placed provider to do that. Sometimes that's a physician, sometimes that's a nurse, sometimes it's a social worker. And so the team-based care that can provide the broadest basket of services possible, mental health services, addiction services, wound care, those kinds of things can all be done in a primary care context, and being able to deliver that in a primary care setting for patients has value. And then lastly, in terms of function, is community adaptiveness, and social accountability. So we want practices to be able to, primary care practices, I should say, to be able to identify evolving needs in the community and respond. And we saw many practices during COVID-19 recognize a need to protect patients by minimizing in-person visits, especially initially, pivot to virtual care so that they could continue to provide as much care as possible, and adapt to the need in the community to continue to provide care safely, because our social accountability is to provide the care that the community needs. So those are the 5 core functions. And then across the top is quality improvement, continuous education, and research. What I want to sort of, I think, articulate as well for you is that if we only focus on the patient medical home, and we don't think about how the patient medical home connects to the rest of the system, we will simply have created primary care as another silo. We won't have created the kind of integrated care that we need and that we know broadly that people want. So we can think of the patient medical home in the context of a patient medical neighborhood, where that practice, that primary care practice, is connected to X-ray services, to lab services, to mental health and addiction services, to hospital services, to home and community care, to social and community supports. And it's important for family physicians and people who work in primary care to be connected so they can refer patients out for those services. But it's also important that those other services respond to the needs of primary care. So, for example, we need in primary care hospitals to be providing their discharge summaries when patients leave hospital to let me know as a family doctor what's just happened with the patient that I care for, so that I can support them when they're back in the community. Hospitals need to respond to primary care and equip us with the things that we need to do to provide best care for our patients. So that patient medical neighborhood concept, I think, is a helpful one for thinking about how we can integrate care in the community. And David, you had a question about cost and outcomes, and Dr. Marsh spoke to the fact that it's actually hard at a whole system level to identify that, but I can tell you that the patient medical home model has been studied, and you'll see the middle box on the right side about cost savings. So in 27 out of 34 studies, we know that the patient medical home saved money. And we know that the other outcomes, if we look at decreasing emerge visits and hospitalization, enhanced primary care, improved quality of care, that in the majority of those studies, there was a demonstrated benefit. And importantly, satisfaction also was demonstrated to be better in the patient medical home model than in other models. And that satisfaction was both for patients and for providers who deliver care. And that's important because we know that satisfied employees are easier to retain. And I think to June's point, we want to retain all of the healthcare providers that we have in our healthcare system currently. So if we can develop a model of care that supports their satisfaction, that they are more likely to be retained in those care delivery settings. I want to share this slide with you as well, because I think it gets at where care needs to be delivered. So this is called the ecology of healthcare concept. And it was originally developed many, many years ago, actually, and updated in the Canadian context in 2015. And what it's trying to illustrate is in any given month, if you take 1,000 people, so that's the big blue box is meant to represent 1,000 people. In that group, and that's 1,000 people over the age of 15, 560 will have one or more diagnosed chronic conditions. So those are diagnosed chronic conditions. That's not somebody being surveyed and said, yeah, you know what, I have a sore back. I always have a sore back. That doesn't count as a chronic condition if it doesn't have a diagnosis in the context of this ecology of healthcare thinking. So more than half of adults over the age of 15 have one or more diagnosed chronic conditions. In any given month, roughly 230 of them will see a family physician in the community. Roughly 70 will see another physician, typically a specialist. roughly 30 will see a nurse, and that's largely because we haven't adopted a team-based primary care. So nurses aren't as easy to see for some people as physicians are in the community context. And then you'll see the tiny box in the corner that only 8 of 1,000 people will have an overnight stay in the hospital. But you'll remember from Dr. Marsh's slide that hospitals take up a huge slice of the funding pie, and yet we know that the majority of care actually happens in the community. And it's maybe a bit of an unfair comparison because the work that hospitals do is very sophisticated and very technological, and so it is costly, but it tends to be where we focus our funding as well, rather than in the community. So for me as Assistant Dean Physician Workforce Strategy, I think a lot about workforce planning broadly. And I think when we think about that ecology of care slide and where people receive their care, then we can begin to think about who are the right people and what are the right skills that we need to provide care to the population. What's the right place for that care to happen? What's the right timing? And can we do it at the right cost? And as your Algoma OHT and local health system evolve, thinking about your workforce and what workforce you need to deliver the care that you want to provide will be an important piece of the work. I think Dr. Marsh had a much more elaborated slide than I have, but I'll just touch on a few things that get in the way. First of all is history. We tend to do things the way we've always done them. And so physicians who have functioned with a fairly high degree of autonomy that in the past, it's hard to shift that. So physician autonomy in and of itself is one of the things that gets in the way of moving to the patient medical home concept. But largely the inertia of the way we've always done things is a challenge. We don't have very good articulated policy about primary care in Ontario. We have this vision of the patient medical home. It's been around in Ontario and talked about. It's found its way into ministry documents for about a decade. It's never been articulated as a policy, and family health teams have not rolled out broadly. So as I mentioned, only 25 to 30% of Ontarians can access interprofessional care, the kind of care that's delivered at group health or through a family health team. And it's partly because we haven't articulated that policy. We don't have intentional system design, and I think the OHTs really are an important venture into intentionally designing the healthcare system. We have not historically had great leadership in primary care at the community and regional level. So we have hospital CEOs, we have administrative leadership in hospital settings, and we have lacked that broadly in primary care. That's changing. It's been slowly changing over the last sort of 5 to 7 years, I would say, but still it's not robust leadership in primary care. And we lack the time and the funding to do the heavy lifting of system change. Just before I close, I want to introduce you, and I'll have a link in the slides that Laurie will share with you. But I want to introduce you to the NUCA model of care. This is a model of care in South Central Alaska. It's run by the South Central Foundation. It's an Indigenous-led system of care with the best primary care metrics in the world. And by metrics, I mean the ways that we measure targets and outcomes. I want to direct I don't know if you can see my cursor, but I'll just sort of circle that 97% customer owner satisfaction. They don't use the word patient in the NUCA model. People who access care are called customer owners. And that thinking, the way that they have designed their system to focus on customer service and the needs of people is really quite profound. The data across the bottom, I won't go into detail, but suffice it to say that really they have the best performing system in the world in terms of primary care. They focus on micro teams. So not large family health teams, not large Ontario health teams, but micro teams, a physician, a nurse, a social worker, all working together for the same population. So a different kind of model, but intentional system design with a foundational focus in primary care. So I'll share a link for you in this list of resources. And I know Laurie will share the slides with the resources for you afterwards. So I'm happy to pause there. I hope I haven't gone too far over time. I have, but I'm happy to take
No.
some questions.
That was perfect. Thank you so, so much, Dr. Newberry, for that excellent overview of primary care. And yes, 100%, we will be sharing those slides and sharing those resources with you all. So you'll be able to check them out after the first weekends. We'll share them with you tomorrow. It's time for Q&A now. So I'm sure that many of you have questions. Maybe a few of you want to try asking a similar question to Sarah. Lisa, I see your hand is up. So I'm going to hand the mic over to you. Oh, Lisa, you're on. There you go.
Okay, Dr. Newberry, I have a question about this idea of the patient medical home and then the patient medical neighborhood.
Yeah.
And I was really interested in what you were talking about around all these services, and if they are, if I understand you correctly, if they're offered in the home, then it's easier to connect and communicate and get access, right? But then they could also be in the neighborhood for those purposes. What I've seen over historically in Sault Ste. Marie is that we have lost services because they were ruled redundant. Therefore, they lost their funding because they were, maybe they were in a primary care setting, therefore you don't get it in the community, or it's in the community, therefore it's not going to be in your primary care setting anymore. And currently, I think we have an issue with lab and diagnostic services, because before you could go into a place like the group health center and your doctor would order, like, need blood work, and they would come and do the blood work while you were sitting in the waiting room. Mm-hmm. Now you have to make an appointment at Life Labs somewhere in the city. Getting an appointment is next to impossible. People who have transportation issues, next to impossible, or different availability because of shift work or whatever. So this idea that, I really like your idea, but it seems like they're trying to cut costs or cut redundancy, and in the end, they're not accomplishing the goals that you're talking about. So I'm wondering if you have any information about that kind of situations.
Yeah, so Lisa, I think that's a great question, and thank you for it. I think ultimately, you know, we have made decisions in healthcare, even in local contexts, that haven't met patients' needs. And we have often done that with a very narrow lens on, you know, this service is redundant or this service is too expensive, and so we're going to cut that and move something over here. The opportunity that I think that you have now is to say, let's start over. Let's think about what the needs of our population are. And, you know, to think about that person who needs an appointment at Life Labs, and how are they going to get there? And what if they have to wait 5 days, but their family doctor told them they needed this, you know, today, and that their family doctor said, I'm worried about your fever, whatever it happens to be. I'd like you to get this test. And then they have to wait, and they miss their ride, and, you know, or they have to spend $15 for the taxi that they can't really afford. We have not designed our system using that patient lens. And that's the opportunity that you have now to say, what services do we need as a population? How do we make sure that we deliver services in a way that's equitable for the whole population? How do we place services where people need them? How do we make sure those services are connected back to the patient medical home, where that care can be coordinated effectively? So your question really is at the root of why I think the Ontario Health Team model has evolved, because it creates that opportunity for intentional design of a system that will work for the people who need it. Our systems historically have been designed for the people who work within them, which is why family doctors sometimes work 9 till 3, and you can't get physio in a hospital on the weekend, because that's what works for providers, but it's not what works for patients. That's what we need to take a big step back and change. Thanks for your question.
Thank you, Sarah. Then up next is Ali. You had your hand up next, so I'll pass the mic over to you.
Okay, so you've talked about these patient medical homes and how they've been implemented. I was wondering if you have specific examples as to where they've been implemented and what were the specific documented reasons for failure. I know you'd posted or within your slideshow some reasons that they weren't considered a success, but I'm looking for direct quotes or documented reasons why they failed, and what was the ratio of success versus failure for these homes.
Okay, so there's a lot of questions there, Ali. I'll do my best to answer them. And so I'll take a little, no, it's great. Your questions are good. I'll take a step back and say that I don't mean to imply that the patient medical home has failed. I don't know that it has anywhere, but what I would say is that we've been slow to embrace it. So for example, in Ontario, we have family health teams. They largely function as patient medical homes in most contexts, but not all. But the government has not chosen to continue to fund interprofessional, interdisciplinary, team-based care. And I think it's partly because there's a cost to that, and they paused after a series of waves of pilots. In the appendices to the PowerPoint that I provided, there is a link to the National College, the College of Family Physicians of Canada. On that patient medical home link, there are several examples, large, small, rural, urban, academic, not academic, that will give you some examples specifically in the Ontario context, in the Alberta context, where the patient medical home has been implemented. And everywhere it's been implemented and studied, it has demonstrated benefit in emerge department visits, hospitalizations, quality of care, cost savings, and satisfaction. So the challenge, I think, is the upfront cost of moving forward with some of those kinds of initiatives. Thank you for the question. I think that answered the pieces.
Yes, thank you.
Great.
Awesome. Thank you so much, Dr. Newberry. Up next, I have David with your hand up. David, do you want to come off mute and ask your question?
There's just a little bit of background noise. I wonder if somebody can mute their line.
Yeah, we'll take care of that. Give me just a second.
Thank you.
Hi, Dr. Newberry.
Hi,
thank
David.
you for your presentation. The question I have is around policy. So you'd mentioned at the last there that policy was potentially a barrier or a challenge. And I'm curious about what levels of policy do the health districts have, the ability to make decisions around? Because I know policy happens at all levels, and so I'm curious if you could elaborate a little bit more on what it means specific to our considerations.
So that's a great question. So the overall funding of things like family health teams is a ministry-directed policy. The way in which we prioritize primary care broadly is a ministry or provincial priority. The next layer historically has been the LHINs, and the LHINs had no either responsibility for or accountability for primary care, except nurse practitioner-led clinics and the community health centers, not the group health centers, but CHCs and Aboriginal Health Access Centers. I don't know why that is. So broadly, there has been no policy around primary care, no accountability for what family physicians do or how they do it, generally speaking. So within your OHT context, I can't speak to what the OHT specifically can control, and perhaps Eric can provide more of that information. But I think you have an opportunity to design some of the elements, at least, of primary care, and to begin to think through how people will be held accountable for the delivery of that care. And that's a big challenge. Physicians in the community have not historically had an accountability to anyone except their partners, sometimes to a board of the family health team, but not always. And many of us have felt an accountability to our patients, or a social accountability, but that's not a contracted accountability. So I think you do have an opportunity to think through what that might look like in your context.
Okay, thank you so
Thank
much,
you.
Sarah. I see that we have 2 more questions, so I'm going to make sure that we get through both Frank and Michael. Frank, do you want to ask your question first?
Can you hear me?
Yeah, we got you.
A lot of the primary care things relate to a family that has a physician. With a number of doctors retiring, etc., what is the avenue open to someone? Is it a walk-in clinic? For example, the wait time in the Sioux for a gynecologist is 1 year.
Yeah, so I think this is a really important question. And when I think about physician workforce planning, one of the opportunities that you have, and I think that health teams have broadly, is to say what is the population, what are the population needs, and then who are the people that we need to deliver that care. So for example, Pap tests for women don't need to be done by a gynecologist. They can be done by a nurse in a family physician's office. You don't even need to see a family physician for that. But there are some steps to building out what that looks like. Who will be the right people to provide the right services at the right time, at the right cost? And that takes some system design. What I would say, Frank, is that there broadly, the panel size or patient roster size for the average family physician practice is anticipated to be about 1,200. So 1,200 people per family physician. That number has to decrease the more that you expect of family physicians. So if you want them to be rounding on their inpatients in hospital, managing the long-term care home, et cetera, the broader the basket of work, the fewer the patients they should probably have in their panel. Walk-in clinics do not generally deliver value. They create a point of access to care, but they don't generally provide the continuity that we know creates safety and value in primary care. And I would say, I think the last point that I would make, and I think it is both an opportunity and a risk, is virtual care, because there is now large corporate influence behind virtual care, Loblaw, Shoppers Drug Mart, who will be very happy to put virtual care in many settings. They already are actually in many settings, and they are virtual walk-in clinics. So you can see a physician essentially by a Zoom appointment. It's an equivalent kind of thing, and they can manage a fraction of healthcare needs. So they create convenient access, but it's not comprehensive team-based care in a continuous relationship anchored to your patient medical neighborhood. So it creates access, but doesn't really create the high value, safe care that we want patients to experience. There is going to be a push for increasing virtual care, particularly in the northern context, because physicians and companies who drive virtual care will make a very strong business case that it's cheaper to have a computer in Sault Ste. Marie or Marathon or Wawa than it is to fund a physician to be retained in that setting. That's maybe a bit of a gross oversimplification, and I apologize for that, but it's one of the disruptions to care that's on my radar very fully, because there's a very big push behind it now.
Thank you.
You're welcome.
Thank you. So Michael, last but not least, I'm going to hand the mic to you to close our question and answer period tonight.
Can you hear me?
I can.
We can.
Thank you. Doctor, in one of the barriers, one of the hindrances you spoke about in terms of putting your concept together of healthcare was physician autonomy.
Mm-hmm.
Could you perhaps expand on how you think you could change that, or rather what needs to be changed and how you think you could change it?
Mm-hmm. So I think it was David who asked about time horizons for the work in system transformation broadly. And I think this is a challenge. We have many physicians in the healthcare system who have prized their autonomy as very important to their professional practice. And it is difficult to shift that. I think with a new cohort of graduates who are speaking the language of social accountability, who want a team-based care environment, who are prepared to give up some independence and autonomy in exchange for somebody who will support the administration and the infrastructure of practice. I think we'll begin to see that tide change. But I think that's on the horizon of years. It really is a culture shift in medicine that we're talking about. And my hope is that one of the gifts, for lack of a better term, of the pandemic is that I think we have a new understanding of how important it is for us to function as a system, hospitals, primary care, public health together in order to serve the needs of a population. And we may see an increased willingness to participate in the system in a new way. And I know that that's kind of a vague answer to your question, and it's a really important question, but I think we are looking at a time horizon of years to change that because culture changes slowly.
Thank you very much. I tend to agree. I think the younger generation, the new graduates, probably are the best bet. But you also spoke about family physicians in particular being individual businessmen. Yeah. And their primary purpose is if you want a profit maximization. That's the way they're paid. They minimize their costs and they maximize their throughput. So it is a very difficult issue. But thank you very much for your thoughts.
You're most welcome. Thank you for your question.
Well, thank you so much, Dr. Newberry, for joining us tonight. And also thank you, Dr. Marsh, who I know stayed on the line. I want to encourage our panelists to give you a virtual round of applause, which if we were in person, you'd be able to be here and hear it with us, but we're going to make the best with what we've got. We are now going to take just a very quick break. So I'm going to propose that we all take about 5 minutes. We get up, we stretch, we move around, grab a glass of water, grab a cup of tea, grab a snack, and we'll meet back here at 8:20 promptly to go through the second part of our orientation. And then we're going to get to know each other a little bit more. Sarah, did you have one last point you wanted to make?
My one last point is just to say how inspired I am by all of you. I am leaving this meeting feeling like, wow, the Algoma area is in such good hands. Thank you for your questions and for being able to engage around this kind of information on a Friday evening at the end of the week. You guys are inspiring. That's terrific.
Welcome back, folks. So we're going to get started with the second part of our orientation. Let me just share my screen here. We're seeing it. It's working. It's an old one. Okay, so second part of the orientation. I'm going to focus this really on talking about how we're going to work together over the next 6 days. And I know that Rukhsaar has shown you the full agenda for our 6 days of work together, and it's, pretty and color coded, but I want to help break it down to you and help you make it a little bit easier to understand. And so my best advice is to think about the panel really as a play happening in 2 parts. So the first part, which we're really in the midst of right now, is really focused on learning, right? We're going to spend most of weekend 1 and then a smaller amount of weekend 2 and almost no time on weekend 3 hearing from formal presentations and getting all the context and the perspectives that we need. And what this means is that's complemented by our second part, which is really the deliberation part of the agenda. And that's when we're going to work together to craft those principles and write those recommendations. So they kind of happen in complementing quantity. So we do less deliberation at the beginning, and by the end of it, we're just doing deliberation. And I can tell you this, I'm going to just put it out there right now because this isn't my first rodeo, but what I can promise you is that by the end of weekend 1, I'm probably going to have a few of you telling me, Laurie, oh, there was just so much learning. It was too much. I can't handle it. But then by the end of weekend 3, when I've asked you to deliberate for like 2 or 3 days, you're going to be going, Laurie, why wasn't there more learning? I missed the learning part. But this is really the way that these 2 parts are going to work together. We have to do the learning first in order to equip you with the tools you need to go into that deliberation part together. So that's broadly speaking what you're in for over the next 6 days. But I do want to zoom in to this deliberation part because it's quite important, and we'll come back to it every single weekend because we're going to build on this. And so when we're talking about deliberation and asking you to work together to produce those principles and to make those recommendations, I want to highlight two things. One is, as I mentioned before, you're a group of 36, but we're often going to work in smaller groups of 6. So think about it like an accordion. We're often going to work in small groups to kind of brainstorm, ideate, get all of our ideas out, and each group of 6 will have a facilitator there to help you. Then you're going to come back as a group of 36. You're going to talk about what each of you guys did. You're going to refine your ideas. You're going to hash things out. And then you're going to go back into your small groups to continue to refine and ideate. So it's kind of like an accordion. We're going in, we're going out, we're going in, we're going out. So that's what a lot of your experience is going to look like and feel like when we're not learning with presentations from our speakers. The second thing about deliberation that I want to just highlight is how we're going to get to the recommendations, because we're not going to ask you to tackle them first. Instead, we're going to get you to first work on selecting a few guiding principles. And these principles are going to act as your North Star. So they're going to be both a kind of like a final output in and of itself. But we start there because it's important to understand really where we want to go. What are the big ideas, the big system outcomes that we want to design for? So we start with principles. Then we're going to list all of the issues, all of the opportunities that we think we want to tackle, right? So that's going to come from your experiences, the experiences of people you know. It's also going to come from everything we're hearing from all of our speakers. But this is really, let's get it all out. Let's figure out what all of the issues are. And then things are going to get tougher, because once we've got all those issues on the table, we're going to have to prioritize. We're not going to be able to tackle everything in 6 days together, unfortunately, finite time and finite energy. So we're going to have some hard conversations about what are the handful of issues and opportunities that we're really going to want to work on as a group. And only once we've prioritized and gotten that focus are we then going to start to delve into and craft those recommendations together. So we're going to layer these things on. So we're going to first do principles, then do issues, then we're going to narrow it down, and then we're going to go deep. That's broadly the process that we're going to be going on together, and we're going to be working on them each of the weekends. So we're not going to get to priorities this weekend. We'll get there next weekend. So this weekend, we're focusing largely on principles and on issues. And where is all of this going? Well, all of this work is going to be presented in a final report that you, the 36 members who have been selected to the panel, will write. So your words are going to go into this report. And I know that that might seem like a hard task, and you're probably going, how is this going to happen? But just like Rukhsaar said, that you're in good company in being amongst a pool of about 1,500 Canadians who have served on reference panels just like this. What I can say is we have written with citizens 40 versions of these reports to date. And I know you're capable of doing it, because I know that one day when I'm talking to a new group of citizens, your report's going to be up there on my screen, and I'm going to be using it to tell them that they can do it too. So I know that we're capable, and we're going to all get there together. The other thing that I want to talk about is our task, because we're here to help you do all of this. So we have a role in all of this. That's me, that's Rukhsaar, that's my facilitation team. We're here to support you through this panel. And as I mentioned before, we really like to think of ourselves as civic concierges. We're here to make sure that you have what you need to do the task that we've asked you to do. That's our job. And so to get really concrete and specific about what that means, our role is to provide clarity. We're here to make sure that you understand the process and to also help steward your learning throughout all of this, which is why we've designed the learning program. It's why we're collecting your questions so that we can get you the answers that you need, but that's one of our core goals in all of this. The second task that we have is to create momentum and ensure that you're ultimately having productive conversations that will allow you to do your task and will allow you to generate that report that we're asking you to do. And as I mentioned before, this is the least favorite part of the role for me, because it sometimes means that I do have to speed things up. I know that a lot of people might at some point feel like the small group conversation could have gone on for longer. And I'm going to have to work with all of my facilitators to kind of figure out how we're going to all work together and make sure that groups are able to come back together and share their findings as a group. So that's just another part of the role that we play in all of this. And the last part of our task is to really make sure that you all feel heard, that you all feel like you're able to participate in this process. And so if at any point you think that something that we're doing could be done better, if you think that something that we're doing could be done differently to allow you to do your work better, I want you to let us know. I want you to reach out by a phone, via email, talk to us on chat during a session if that works best. But really, that's what we're here for. And if there's something we can be doing differently, then I'd really hope you let us know so that we can have the opportunity to make it right and enable you to do your job better. So that's a little bit about our mutual roles in all of this. The other thing I wanted to just talk about is I know that we're talking about health and health systems and healthcare. And when we bring a diverse group of people together and we talk about really complicated issues that might be really close to our personal lives or personal experiences, what I want to just say is we don't have to agree. We might not agree all of the time, right? Stephanie said that's part of, living in a bigger community, living in a broader society is about. However, we do have to disagree with respect. So what I want to propose are 5 pointers to help us do all of this together. So the first, this is one of my favorite rules because I'm a chatty person, as you can probably tell. But I want to encourage you all, especially the chattier folks in the room, and I say this humbly, I want you to listen with the same passion with which you want to be heard. Right? And so try to refrain from interrupting folks. And I know it's easier when we're in person to kind of jump into a conversation, but on Zoom, it's so much harder, right? So, wait until someone's finished speaking, use the chat box, use the raise hand function. It makes sure that we're allowing everybody to say what they need to say. And to build off of that, I want to encourage us all to make space, right? So to balance our own contributions with those of others. And so one of my kind of rules of thumb for this is when we're in small groups, we're usually in groups of 6. So a good way to think about this is you should probably be speaking for about 1/6 of the time and probably listening for about 5/6 of the time. And if on balance, that's roughly where you're ending up, we're probably doing okay. We've stressed this a lot, and Rukhsaar said this when she asked you to stretch yourselves and think on behalf of the 150 people who didn't win the civic lottery and the 7,500 who weren't able to join us tonight. But I want you to consider those who aren't with us tonight, to really do our best to put ourselves in someone else's shoes and to see what solutions or ideas we're talking about, what that might look like from their perspective. I also want us to allow ourselves to make mistakes. We're all learning in this together. I'm not a healthcare expert. You're probably all not healthcare experts. And that's what makes this really exciting and really fun. We're all going to have new ideas and new ways of seeing this to bring to the table. But when we're learning, we also sometimes get things wrong, and that's okay. So what I want to encourage us all to do is if we get something wrong, if somebody corrects us, we just say thank you. We apologize, we learn from our mistakes, and we continue to work together. And lastly, I want to just basically encourage everyone to join me and my team in creating a welcoming space. This is really something that is everyone's responsibility. Each one of you deserves to be here. Each one of you is qualified to contribute, and you all have really great and interesting and important experience that we need to learn and draw from together. So that's just kind of my general rules of thumb for how to work through this. And the only other thing I just want to mention quickly is because this can be a challenging and difficult topic for some people, health is something that is personal, it is felt, it happens to our bodies. If you are dealing with a subject that you find emotionally difficult, if you need to step away, I want to encourage anyone who needs to do this to please do so. If possible, if you're up for it and it's appropriate, I would encourage you to message either Rukhsaar, myself, or your small team facilitator, just to let them know that you're taking a break and to let us know if, when, and how we should check in with you. And additionally, I wanted to let folks know that we're also available to speak after the meeting. You can either message us on Zoom during the meeting, let us know, we'll pick up the phone and call you, give us a shout at our email, or give us a call at the toll-free line. But we're here to help, and I just wanted to put that out there. But we've been talking a lot at you this whole evening. And so I actually want to get to know, I want you folks to actually get to know each other a little bit better. We're going to be doing the big group introduction tomorrow morning, but tonight what I'm gonna do is gonna send you all out into breakout rooms to start to get to know each other in a little bit more intimate level over a smaller Zoom discussion. But before I did that, I just wanted to give you a glimpse of who is in the room. We've talked a lot about representation and the fact that you were randomly selected in order to make sure that, you know, you roughly looked like the region. So I just wanted to give you a sense of what that looked like. So in this room of 36 people, this virtual space, we've got an even mix of men and women. We've got a range of different age groups in the room. We've also got a wide range of different lived experience. We have folks who self-identify as Indigenous, as either First Nation, Métis, or Inuit, folks who self-identified as Francophone, as racialized or a visible minority, as somebody who has a disability, or somebody who is low income. So we've got a real wide range of perspectives. And we've also got people who have different experiences with the health system. We have some of you who have identified as frequent users of the health system and others who have identified as infrequent users of the health system. And I'm noticing here that both says infrequently. Infrequently is the larger circle, frequently is the smaller one. I'll correct that. And last, we also have some folks who have access to a primary care practitioner, and we have some folks who don't. So all of that is going to inform your discussions and allow us to have a much richer discussion. And if we put all of you on a map, you can also see that you come from different parts of the Algoma region, right? So some folks from the east, some from the Sioux area, some folks kind of outside of the Sioux area, other folks up north. And all of that is also going to shape your experience of the health system and also probably what you think needs to change and how to change it. So I just wanted to put that into perspective before we sent you into your small groups. But without further ado, what I want to just encourage folks to do is we've created a few questions just to help, whoops, that went ahead too much, just to help get the conversation started. So what I'd propose you do is you introduce yourself, tell people where you're joining from, maybe talk a little bit about why you volunteered. And then if you want to share something that you think folks should know about you and what you're hoping to learn during the panel. So we're going to go for about 20-25 minutes in small group discussions, and then we'll come back together, say goodnight, and join tomorrow morning for the second part of weekend one. Rukhsaar, are we good to go for breakout rooms?
Yes, I did notice that I think Ron had a question. He raised his hand.
Oh, perfect. I did not see that. Ron, did you want to ask your question really quickly?
Sure. Can you hear me okay?
Yeah, I can.
It may be an obvious question, but who is this report going to? Who is it going to be disseminated out to? And what authority will the report be held? Meaning our recommendations, are they must be followed, might be followed, or this is just good show?
So it's a great question. So Stephanie Parniak, who joined us earlier, was explaining this a little bit, and we're going to go into greater depth tomorrow about this. But the Algoma Ontario Health Team is going to be the kind of receivers of the report, along with their peers in the east, as well as their peers in the north. So it's 3 different health teams who are part of this project that have convened you together. But part of the health teams are different service providers. So we'll also be sharing the report with different service providers across the region. We're going to talk more explicitly tomorrow. We have Mary Ellen Lukonen and Eric Landrio who are going to be joining us to talk much more explicitly about what a health team is, what their purview is, what jurisdiction they have, because one of the things we do want to help you get clear on is ultimately what levers are available, like what is the sandbox of change that's possible. And Dr. Marsh started to articulate that today when he talked about some things being at the federal level, we're not talking to those folks. Some things being at the provincial level, we're not talking to those folks. We're talking to the health teams, and they help organize service providers working on the ground. So it's a great question, and we're going to get into that a little bit more in detail tomorrow to help you better understand that. And in terms of the kind of what the recommendations are, they are recommendations. So it is advice that you will be giving to the Algoma Ontario Health Team. And they will then use it, as Stephanie mentioned, to do two things mostly, but they need to deliver a patient charter of values. It's one of the things that they're working on at the moment. And so your principles that you'll be creating will inform that creation of that document. And they also need to create a strategic plan, which will set out priorities for the entire region that will focus the system. And so we're really going to talk a little bit about what are those issues and what those priorities should be. So that'll be one of the considerations of the Ontario Health Team as they make their first strategic plan. But great question. Cool. I see. I like that little sign. It's a good emoji too. I'm going to send you all out to your breakout rooms, but I don't want to stop folks from asking questions. So if you do, either let your facilitator know and they can let me know and we can tackle them tomorrow morning. But I am looking at the time and thinking I want to give you folks a chance to get to know each other a little bit tonight before we pick up tomorrow.